Okay, well, thank you everybody who is on right now. Let's go ahead and get started. I'm excited. I first want to thank Daniel and Tori Victoria for their coordination of this event. Thank y'all so much. I'm excited for this discussion. And so, for those that are joining, this conversation will be topping health equity considerations, COVID-19 and racism. And so we're going to go ahead and start by just introducing ourselves. My name is Jason Deakins. I'm a PhD candidate with the School of Public Health and Information Sciences at U of L. And I'm also the SGA Council for Public Health President. We have Victoria Clemens. Victoria Wave, say hi.
Hi, my name's Victoria.
She is an MPH candidate at U of L. And she's also the SGA Council grad rep. And then we have Daniel. Daniel, say hi.
Hi.
Daniel's an MPH candidate. I'm an Epi, right, Daniel?
Yes.
Yes. And he is also the SGA Council Treasurer. So without further ado, let's go ahead and get started. And let me introduce our panel. I want to first thank our panel. Thank y'all so much for taking the time to come and join us in this conversation. This is awesome. I'm excited. So first we have Dr. Ruth Carrico. And she's a professor at the School of Medicine, Division of Infectious Diseases. A little bit about Dr. Ruth. I'm not going to read their entire bio, but Dr. Ruth received training for healthcare epidemiology and public health at the Centers of Disease Control and Prevention in conjunction with the Rollins School of Public Health at Emory University in Atlanta. And she also served on the National Board of Directors for APIC, as well as acted as a reviewer for the American Journal of Infection Control. Infection control and hospital epidemiology, and critical care medicine. So then in 2018, she became the president of the Kentucky Nurses Association, and in 2020 was recognized as a distinguished fellow in the National Academics of Practice. Say hi, Dr. Ruth.
Hey.
And then next we have Dr. Ann Wallis, associate professor in the School of Public Health and Information Science Department of Epi and Population Health. A little bit about Dr. Wallis. She's the MAIA study, a longitudinal study of pregnancy in Romania. She's a Fulbright scholar with a recent appointment in Armenia to study environmental health and an upcoming appointment with the University of Gambia. And she received her PhD in maternal and child health epi at the Johns Hopkins University Bloomberg School of Public Health. Say hi, Dr. Wallis.
Hi.
Last but not least, we have Dr. Billie Castle. A little bit about Dr. Billie Castle. Earned her Bachelor's of Science in Health Sciences from Howard University in 2012. Her Master's of Public Health and Health Policy and Management from Texas A&M University, and completed her PhD in Public Health Sciences right here at U of L in the School of Public Health and Information Sciences and Health Promotion. She currently serves as the Youth Development System Administrator in the Office of Youth Development, a division within the Louisville Metro Office of Resilience and Community Services. And Dr. Billie Castle is the president of the Louisville Urban League Young Professionals, a member of the Pi Lambda Omega chapter of Alpha Kappa Alpha Sorority Incorporated, and a board member with the American Cancer Society. Dr. Billie, say hi.
Hello.
It's so good to thank y'all so much again for taking your time out to join us. I'm so excited. Okay, so at Public Health SGA Council, y'all, we had a meeting discussing things that we were concerned with. And out of that general meeting, we decided and came to the consensus of racism is a public health emergency. It's a structural determinant of the social determinants of health. Systemic racism drives disproportionate morbidity and mortality across a spectrum of health issues, from epigenetics to infectious disease to chronic conditions to mental health and trauma. And with COVID-19, our emerging public health crisis, it's showing similar patterns of morbidity and mortality weighing more heavily on Black Americans than it does on white Americans. And so anti-racist work in public health means prioritizing and addressing and dismantling systemic racism, investing meaningful resources to do that, and confronting and changing our own behaviors. And there is no longer room, it's our opinion, there's no longer room for people to hide in the middle and claim that they're not racist and they're not going to participate in a change initiative. Racism and anti-racism do not form a continuum. It is a dichotomy. If you are not anti-racist, which is actively engaging in efforts to change our racist policies, then you're racist. So we're really excited to get started. So with that, I'm going to head it over to Daniel and Victoria. Y'all take it away with the questions.
Hi, guys. So for the opening question, we like for each panelist to answer this opening question to get us started. As we know, racism as a public health issue. We now understand that trauma related to direct and institutional racism has broad spectrum health implications. As such, it is necessary to synthesize established knowledge related to health effects of racism with emerging health issues, including COVID-19. So drawing from your experiences in public health, what do you think the first or most fundamental step is in addressing COVID-19 in a way that is equitable in our community?
Who do you want to start with?
Anybody, whoever wants to go first. This is an open question.
Well, I'll jump in there and start. And if I can, I'm gonna share my screen because I put together just a couple of slides, and I think this fits very nicely with our discussion because we're talking about the issues of COVID-19 and its impact. And I want to just start off just with the baseline that I think everybody realizes that COVID-19 is a disease of every body system. It affects not only lungs, but it affects every body system. And this is important as we are talking about the issues of health equity and how this impacts then our entire population. So I want to take you through just a little bit of a discussion about how disease and where disease and what we know about disease in our community. So quickly, this is just this is the city of Louisville and the census tract. These are cases of community-acquired pneumonia that a study that's led by my division chief, where every patient that has community-acquired pneumonia is a dot on this map. Now, bear with me because I know we're talking about COVID-19, but you're going to see the relationship. So this is the distribution in the city of pneumonia. And I'm sure you already see some areas where in this heat map where we've got a little more heat than in other areas. And if we look at these maps, we can see that the disease of pneumonia and severe pneumonia and poverty are just right on top of each other. So I think as we're talking about this disease where we have very little immunity, we have no treatment, we have no vaccine yet, and we have then a disease that causes tremendous illness. And we see that infectious diseases, and this is just one example of many, every single disease, health, defining condition, we see this in areas of poverty. So I want to, I guess, challenge a little bit of the discussion. When we talk about a health issue and race, we make it about race, when instead I would challenge to say it's about poverty. And so unless we address the issues that can impact poverty and access to care and value for health care and ongoing health care, we're not going to be able to address any of the issues that I think continue to divide us. So as we talk about then COVID-19 this evening and use that kind of as our marker for what is happening in our community, how well we are addressing this or how well we are not addressing that, I also want to just make sure that we're thinking about the whole person and that we are not making any assumption that someone who is white or someone who is Black, because of the color of their skin, is more likely to have disease. Instead, we're saying that if we have an individual that does not have access to health care and that we start that slippery slope, then how will we address any of these public health issues? So with that, let me turn it back over to the group as we dive into tonight's discussion.
Dr. Castle, do you want to go next?
Yeah, so I was going to say, adding with that, thank you for the map, because I think it brings me to the Center for Health Equity's work and their maps. If you think of their they're iterations of their health equity report, but more recently, the 2017 health equity report that really outlines a history of Jefferson County and Metro Louisville that really, yes, poverty is a part of that. But strategically here in this city, it's been impacted by redlining and thinking about even going further back to 1914's ordinance of separating white residents and Black residents from living on the same streets. We know that a lot of that is very much connected to why we see maps where we see concentrated disparities in certain areas as opposed to other areas of the city. And you can, again, as you showed in the map, overlay any health disparity and you're gonna see the same thing. And not just health disparities, with all root causes. So we talk about access to food, we talk about transportation, we talk about homicide, criminal justice, all the root causes here in Jefferson County. A lot of it is very much impacted by, we talk about your zip code determines your health outcomes. So with COVID-19, where you live also is just determined, your outcomes are determined by your zip code.
Did you get refined?
So one of the things I was going to add is, yes, and poverty is definitely linked to systemic racism. So here in this Jefferson County, when we talk about COVID-19, but largely any issue here, we have to go back and think about what got us to this place. And a lot of it is the systems and policies that have created the social environment in which we all live. And so those outcomes for, white residents or Black residents are different because a lot of those historical decisions and things that have happened. And so that's where I'll go with that. So that's why we see a lot of those outcomes, and our decisions really need to think about it in terms of how do we get here. Not just COVID-19, but all health outcomes are very much directly linked to a lot of racist policies and systems here, not just in Jefferson County, but we see that across the nation, and why our numbers for COVID-19 are the way they are and impacting certain communities.
Thank you, Dr. Castle.
So I'll go. Thank you, both of you. That was great. And I think it sets us up really well for the evening. So as an epidemiologist, I think a lot about data-related issues, right? And as a social epidemiologist, I think a lot about social effects on health, including socioeconomic position, poverty, neighborhood of residence, occupation, etc. I'm also interested in race, particularly in how we operationalize race and racism as variables. I think we all agree that race is not a thing. We know it's not. It's not a biological thing, but it is a marker for other factors, just as Dr. Castle just said, so like poverty or environmental exposures. So what I think is of great interest is racism and perceptions of racism, and how we take a deep dive into really understanding what we mean and how we measure it. So the question is, how does racism get in the skin? How does it get in the body? So, when we talk about first steps, my first step would actually be to measure race in COVID reports to the CDC in a lot better way than they're doing. Right now, it's really spotty. So what they're able to show is that for Black and Native Americans, they're about between 2.5 and 3 times more likely to be diagnosed with COVID. Black and Native Americans are 4 to 5 times more likely to be hospitalized and twice as likely to die. However, the data that they have is it's pretty inconsistent. Better data means that we know the situation better and we can know how to act. And yeah, that's my thoughts to start.
Thank you, Dr. Wallis.
Thank you, Dr. Wallis.
So my first question was going to be for Dr. Carrico about trends that we've been seeing with COVID-19 within the Louisville community, but you excellently displayed that with the maps. I love ArcGIS and map data, so I'm really glad you included those. So I guess you kind of answered that question ahead of the game. So I'll ask Dr. Wallis if you could elaborate more and explain kind of, as an epidemiologist, how inequity and social injustice are producing those health consequences. So like you just asked, how does racism get under the skin?
So what I would propose is that unequal access to housing, historically through redlining, like Dr. Carrico said, and presently due to the cost of housing and just segregation and racism, where you live matters. And I've been really interested in that in my work, about how place affects your health. So that could be exposure to lead and other pollutants. We know that there's more lead in the soil in West Louisville than in other places. Poor policing, noise, overcrowded living conditions are all stressors that can affect the human organism. So if we think about racism as a stressor, we know, for example, like in my work, I know that stressors impact pregnancy in really important ways. Like that's a big risk factor for preterm delivery. So, but also racism can be lifelong and highly traumatic. So it includes exposure to persistent microaggressions and intergenerational trauma, like serious trauma. So the question is then, how does racism in all its forms get into the body and under the skin? Can it cause epigenetic change? And we sort of think that maybe it can. What does 400 years of oppression and trauma do to the human body? I would suggest that it weakens and ages the body, making people much more susceptible to chronic and infectious disease. So that's where I would go with that. And that's, yeah.
That's an awesome insight. I would have never thought to think about racism in that form. Thank you, Dr. Wallis. Next for Dr. Castle. Many Americans, when confronted with evidence of health inequity, respond that the outcomes are unfortunate, but not necessarily unjust. What is your response to that? And where or whom do you believe responsibility to address these inequities lies upon?
So I think adding to Dr. Walls just mentioned the there's a book that talks about post-traumatic slave syndrome. And
Great.
So it being in the DNA of, descendants of slaves, and thinking about how that's passed down is things that we think about. So for me, in my research and work, I think about how we use a critical race theory framework. And so when you ask questions of how do we get here, how do we address it, we need to really make sure that when we're answering these questions and talking about things, we directly link it to how it came to be. How did America get to its current state? How do we have these policies? How do we create these social environments in which we live that dictate our behaviors? And so I think about, as we're talking about systemic racism and how it gets into everything we've done, it really goes back to thinking about how America started, and how it was framed by the forefathers. And when we think through, how everything is set up and how we continuously see through, all these generations, more and more policies and practices put in place to continue to create oppression in these gaps within all of our health, all these outcomes. So when we see inequities, a lot of time, yes, it's like, oh, the people don't want to eat better. Like people, that's why they're obese, or, they don't want to exercise, or people are lazy. That's why they live in poverty or have to be on assistance. So we I know we all think about the socio-ecological model as we talk about things. And so for me, when I think about the socio-ecological model, I think about how those outer rings impact everything in the inner rings. And so when someone says, like, how do we fix what's happening? We got here because of decisions from those outer rings. So that is how we need to work and think about, I think you all said, like, who do we place blame on? We place blame on the social environment created through those policies and practices, like redlining, that create neighborhoods that haven't been invested in and create those housing conditions. Because yes, our where we live dictates our health outcomes, our life expectancy. So knowing that I live in, I think the Russell neighborhood probably has the lowest life expectancy right here in Jefferson County, which is about a 12-year difference between one of the neighborhoods that has the highest life expectancy rate. And they're about 2 to 3 miles apart from each other. So why am I so close to a neighborhood that has higher life expectancy rate, but the things I have access to, food, transportation, job, thinking about the environment, so lead in the soil, as well as the opportunities I have, are dictated by where I live. You know, we say, oh, there are people who make it out, but a lot of times the people who, quote unquote, that, you know, society say make it out, are because they have access to a lot of the things that will help change their outcomes. But it's not that they found it in their neighborhood. They had to go outside of their neighborhood to access a lot of those things to get it. So when we talk about who fixes and how do we fix these inequalities, we definitely have to take like a place-based approach to it and making sure that we are addressing those root causes in a place-based and not one at a time. So we're going to fix education first and then we're going to fix food. No, we have to work on all root causes in a place-based setting to make sure that we're addressing the health inequities. Is where we should be talking about when we talk about who do we place blame on. So for me, I place blame on these systems that have created these social environments of inequitable neighborhoods. If we divide it in neighborhoods, and that is how we should fix it. We should dismantle those unjust systems and create systems that are equitable, and making sure that we are first starting off with those marginalized populations and making sure that those neighborhoods are at the baseline indicators for a county. So like Jefferson County, let's use Russell neighborhood again. So the median income for Jefferson County overall is like $55,000. But the median income for the Russell neighborhood, where we're talking about with the life expectancy differences, is about $12,000. So if we think about, you know, fixing inequities, the neighborhoods that have those gaps need to be, you know, addressed first and at the median baseline as we talk about poverty. First, and then we need to make sure that we're working hard to continue to build these systems that are accountable to being equitable as well, so we aren't going in the reverse and widening gaps. Because right now we're trying to fix broken things, and it continues to widen the gaps because we're using those we're not being innovative. We're using those same approaches to try to fix things that have been broken for generations. And we need to be more innovative in the way we're addressing a lot of the inequities.
A great answer. Jason, do you have something to say?
Yeah, just really quick. So I noticed Daniel's question. So I had to turn my camera off because I have the book right here. It's
That's the book.
by Dr. Joy DeGrasse. So she's amazing. She has like lectures and webinars on YouTube for anybody to look up. But I also wanted to comment on Dr. Wallis and Dr. Castle's response, because I think, you know, it would be not smart of us to just cover what we've just went through in the past week and with the Breonna Taylor decision, because when I tell you that as students at the University of Louisville, especially specifically a Black student, I had a physiological response that I could not work. I don't know. It was like I couldn't move. I didn't feel like getting up. It was a physiological response I had to that. It was oppression to me. It didn't happen to my family, but it happened to me because it was like, that could have been me. That is my family. Yeah, I have family, you know what I mean? So it was a physiological response that I felt. It traumatized me. It triggered me. And I immediately, when we had the decision, I was like at a restaurant. And what I did was, had it propped up on my phone on Facebook Live when the decision came out. And it was interesting to me to see the response, like my response when I was with a group of Black friends, Black students, and everybody else's response who were watching it, but were not impacted the way I was. And so to me, that also gave evidence to Dr. Wallis's point and Dr. Castle's point of like, it literally impacts my being of that oppression, that trauma. And so like, for me, even when Dr. Castle was talking about systems, academia is a system that has been oppressive to me. As a doctoral student, I'm at that point now. And and Dr. Wallis knows, everybody knows me, except for Dr. Carrico, but I speak freely. So, you have to excuse me, but it literally has been hard to keep going because you have things to do. You have lectures to do, you have dissertations to think about, you have papers to write, you got lectures to go over if you're a student, still a student in coursework. And so that was hard. And I think what U of L could improve on, and I know there's some people on here that are on like CODRA and the anti-racist agenda for U of L who have thought about ways to meet our students where they are, specifically with what happened just recently. And I think we just need to do more of that. And that's a system level thing. You know what I mean? So Dr. Castle, yes. Dr. Wallis, yes. I just wanted to add my 2 cents. Sorry, y'all.
Thank you for that, Jason.
Yeah, and I want to add, anti-racism work isn't just a one-off thing. Anti-racism work needs to happen every day in every decision, in every course, in everything we do. I think that a lot of times when we talk about anti-racism work, it's very specific to, responding. We are very reactive culture. Reactive culture as opposed to really being on the forefront of things. And I think that, as you talk about academia being oppressive, absolutely. And especially if you think about, I talked about critical race theory framework, but also being intersectional and a lot of things that we talk about, how all our different identities are also impacted by these systems is something you have to talk about. But like anti-racism work isn't just in reaction to certain things. It needs to be ongoing in every day and everything we do. And I think that a lot of systems are very hesitant to do it daily because we're like, this is the way we've always done things. But clearly the way we've always done things yield the same results and further the gaps. So why are we scared to really do things different?
Right.
Thanks.
So what Jason's response was, I saw in a lot of my students and other faculty and all of us really. I mean, I think Louisville was in shock last week and still is. But, when we start to talk about the institutions, the University of Louisville is a state university. And over the last, 15 or 20 years, state universities have received less and less funding from their states. You would be surprised, I think, to know how little funding the U of L gets from the state. It's like 10 or 11% total. Okay, so what that means then is tuition goes up. And when tuition goes up, access to higher education is harder for anybody who's not middle class, right? So there's that, and that's a structural issue at the state level. And then I think the other thing with higher ed is that we just have to look around us, and I almost hesitate to say this, but the professors the higher administration, they're white men. So who do women, and thinking intersectionally, like Dr. Castle said, who do women, who do people who are of color, people who are LH or LGBTQ, who do they look up to? Do you have professors and deans and provosts who look like you or not? And the answer right now is we don't.
I really liked what Dr. Castle, you said about the systems and the social determinants of health and the socio-ecological model, and how there are these system level institutions that are putting pressure onto individual and interpersonal relationships, and these are the systems that are putting on the pressure and the health inequities, but we're expecting the individual and the interpersonal level to be the one that changes these larger structures. And I don't know if I have a comment, but it's a lot. It's a lot to process.
Thank you, guys. Thank you for your insights.
I was gonna say, easy thing to say is it's the people, because it takes away the accountability of the decision maker. So of course I can say oh, it's the people's fault they're doing that, because then if I keep saying it's the people, then it takes away me having to do anything.
I was gonna ask Dr. Carrico maybe could speak on this, because again, of her maps and her understanding of the trends of the prevalence and burden of disease in Louisville. And Dr. Carrico pointed out the relationship between poverty and these patterns of disease. And I was wondering if you had anything to say about the difficulty of analyzing and understanding research in Louisville, because we have everything everywhere is connected, but especially in Louisville, which like Dr. Castle pointed out, has a history of redlining. All of these issues are so connected. So how do we understand the impact of poverty and then the impact of racism, or are they even different? Are they just the same thing?
I think, at one of the basis of one of your questions is, how do we make sure that when we study an issue, that the population we study is representative of the population where we have the concerns? And this is always our issue when we're doing clinical research. Are we including are we getting a full picture of the population? And this is one of my concerns as we look at COVID-19, and we're thinking now about a vaccine release. Are we going to be able to talk about and answer the questions that different populations may have about a vaccine? Is it safe? Do they have confidence in not only the vaccine, but in the distribution? Because let me throw out a situation. One of the issues now with vaccine is that one of the top priorities is the healthcare worker that is actively caring for someone with COVID-19. So we have, maybe if you look at everybody that is involved in the work of healthcare, it's probably about 100,000 people in our community, in our population of 800,000 people. But not all of those are in jobs where they are upfront and up close and personal with patients that are ill, so that they're really not involved in that exposure issue. So maybe we're looking at 40,000. Well, what if we only get 10,000 doses of vaccine? How will we make decisions? Should we make decisions based upon the job that is done? Maybe I could say we could get, about all the nurses that would be involved. But what if we don't have enough for all of the nurses, and we start making some prioritization? Should we prioritize those nurses where we would expect that there would be then the greater risk of having a negative outcome for COVID-19 and infection? So should I say that we're going to prioritize then African-American nurses ahead of Caucasian or Asian nurses because of the outcomes that we see. And if we agree with that, how do we then encourage people in that targeted group to accept vaccination? So we're kind of in that catch-22. How do we have that level of trust where we can say, we recognize the risk. We want to encourage you to accept a vaccine that has been approved by the FDA, reaching this. And then is someone going to say, wait, you only want me to have this vaccine? It's just like Tuskegee. You know, you only want me to have this vaccine because you're going to experiment on me. So how do we get to that point where we are able then, what is the message that we need to deliver? How do we need to deliver that? So we then have the ability to begin this process of changing health outcomes. If we want to get there, how do we do that? Is it messaging? Is it, how do we collect the data to be able to do that? How will we bring science and the science of medicine, the science of public health, the science of sociology, and everything together to enable that change to occur? And I think these are very real questions we're gonna need guidance from, because I expect this to be the challenge in front of us within the coming weeks.
Yeah, I think that's an excellent point. Building trust between the healthcare system and the people it's supposed to serve is, it's foundational to being able to serve them. And it's also, unfortunately, public health has atrocious record, especially with marginalized communities. So that's an excellent point, yeah.
Thank you, Dr. Carrico. So I guess this is just going to be the perfect shift to our next question. This is going to be specifically, so now we're going to move to general questions, and it's going to be 2 panelists at a time, taking turns, obviously. So this one is for Dr. Carrico and Dr. Castle. What does your organization do now to reduce health disparities and move toward greater equity in health? What else could your organization do? What are the chief obstacles in doing more?
Well, I think just from a research perspective, and I'll talk about the research, and then Dr. Castle, if you can help us then figure out how do we get there, then how do we, if we're going to learn and we are going to understand the scope of the problem and learn from the population, how do we better engage the population in research and helping us understand the problems? Because as you have mentioned, if we keep doing the same thing over and over again, that's our definition of insanity. So what are those innovations that we need to do to begin to help us take that next step? Because we're going to have to hear that, I think, not only from the populations that are the most deeply affected, but from those that can help, I guess, mediate between the old way of doing things and what the new way should be. So how do we? I don't know, but we're having to learn from the next generation on how to do that more effectively and, I guess, more compassionately.
So for me, I think about if we solve a couple things, and we've talked about poverty. So for me, if we go and really address root causes, a lot of the health outcomes would be changed. So what could my organization do, or what could organizations do, is really impacting root causes for a lot of the neighborhoods that have been divested and impacted. Let's use redlining as an example, by the impacts of redlining. Because we think about, once we change like access to healthcare, food, transportation, all these things, these social and environmental factors, we'll see a change in health outcomes. Another thing I want to throw in there is, we talk about like, how do we address and get people, how do we address COVID-19? I think that we have to also be honest and know that capitalism has impacted the US and a lot of decisions that have been made. And so how has I want to throw that in there as I've talked about systemic racism, but how also has capitalism really impacted a lot of, especially in the last couple of months, decisions that have been made at, you know, federal, state, and local levels around the pandemic. Because if you think about it from a community perspective, and even I think about myself personally, there are a lot of mixed messages out, but not even just mixed messages. When there are states doing different things and you see, we're talking about data, I definitely agree we need better data, but it's hard to have that better data when everybody's not on the same page. So where Kentucky is doing one thing, we're right across the bridge from Indiana, they're doing something else. So Indiana's like all the way open at this point because they're in stage 5. But I don't even know what stage we're in here in Kentucky. Maybe I think we're in 2, but you can't really tell where we are. And there's some people who are like, there's a pandemic happening. So there is currently a lot of mixed messaging. And for me, a lot of that I will attribute to in adding capitalism and how this drive for us to get back to quote unquote normal and do things as we've always done really impacts, it's gonna impact, 1, how we collect data, and 2, how we recover, because a lot of people aren't trusting. Like I personally, I'm like weary of a lot of things, even with the knowledge of understanding how research and participating in things will be helpful to everybody. Sometimes I'm even skeptical about it because I think about Tuskegee, yes, I think about Henrietta Lacks, I think about all these things that have happened, especially as a Black woman, in the name of research, in the name of science, that one, doesn't make me trust the systems, but also all these other competing things that I need done and happen in the community aren't really being addressed. And then you throw something else there. And then here in Louisville, we also talk about the social unrest and Breonna Taylor decision in case. So all those things are happening and all these different mixed messaging. To your answer, Dr. Carrico, I don't even know, because with all these things happening and all this mixed messaging, and now if we think about, okay, so Tuskegee happened, let's compare it to 2020. There was not social media. Other people didn't know this was happening. A lot of people in the community didn't know it was wrong. But now in this age of technology and information that you have at an instant and a second, you don't even know what to trust. So if I think about now people know, like, all these things happen, I can't really trust the system. Who do I listen to? Because if one state is saying this, one state is doing this, we're not believing our leading experts. So who do I trust? So as a community member who has been impacted by all these other decisions, it's going to be hard for me to say, like, hey, you need to take this vaccine, or hey, participate in this study. And it's even hard for me to ask people to do those things, because then I get all these rebuttals like, oh, it's not real, it's fake, it's this, you know. So how do you get there when overall as a country, we aren't even on the same page of how do we address anything? So I really have been thinking about this question since you sent it to us, like, how do we address like the pandemic right now with all these other factors included? And for me, the answer is going back to us being reactive to one disparity at a time. My answer is always going to go back to, we need to address root causes. We need to make sure that people have all the things that they need, so that when a COVID-19 pandemic happens, or like as flu season is starting, or like all these other things happen, we saw the pneumonia map, we will see the outcomes in neighborhoods that have been impacted go down, because all my other basic needs are met. But when my basic needs aren't met, and then you throw at me racism, you throw at me a pandemic, you throw, if you think about families who have NTI and everybody's in the house, we don't have enough internet, or everybody's online at the same time and we can't figure things out, it's going to be hard for any messaging to go out, because there's like a whole lot of things and a whole lot of messages going out at one time. So what am I supposed to do? What do I address first? And I think that question has been a question for communities that have been impacted by systemic racism for generations. Like, what do I do first? And a lot of times that's getting my basic needs met at any means necessary. And so that is really how I say we need to address it. We have to really address our root causes. I'm going to always go back to that.
So, you know, I guess there's that Hindu proverb or parable about the guys that are three blind guys that are all touching a different part of the elephant. And, you know, they're describing the elephant, of course, very differently from their perspective. So I think, you know, one of the challenges that we have is how do we stop being paralyzed because of the overwhelming number of things that need to change, and then begin to change the things that methodically that need to be changed. So, you know, you mentioned the children, that right now we are seeing the education gap growing because children aren't in school, that we're not going to be able to address that. And so what happens if we then start schools back again and have children back in school together? And, you know, we know that that's going to create a lot of issues. And I'm not saying we shouldn't have children back in school. I mean, just the opposite. I feel like we need to have the children back in school, because the children need to be the focus of, you know, what happens in the future, getting them back to begin that socialization and getting them back then to learning to keep that gap from widening, I think is incredible. So whatever that first step is, we know no matter if there are 50 steps to take forward, the one that's chosen as a first step is going to be, you know, vilified by the portion of the population that doesn't think that was the most important to do. So as we move forward, then I think we're going to have to be able to accept that we're not going to be able to make every decision happen, every decision right, and do everything that needs to be done at the same time. That change is going to have to be incremental, that, you know, we can't change everything because we don't know what the right thing necessarily is to do for the population. So I think, you know, by having groups that will help us understand the actions and the directions so that we can make the most reasonable approach possible, and then invest in those approaches. And then investments that can, you know, be measurable, that we can say, this works, let's do more of it. Or if it doesn't work, then let's do less of it. So still having that, you know, the ability to study the problems with an element of science is something that we have to do, or else we're back in the knee-jerk response and trying to figure out what are those root causes. There's not just one, right? There are going to be many roots to this problem. Which ones do we start pulling up first, or which ones do we chop first? I think that, you know, that will, of course, I know be significant debate, but the more we debate the issue, and the less that means we're distracted from the work. So how do we move forward? I think that's the question and the anxiety that many of us have, that we want to move forward with that. What are the best initial responses to do? Not what somebody else does, not what, you know, it's what do we do in our community that is led by people in our community to begin to make that change and be accountable for that change.
Yeah, that's an excellent point. I think it's also hard to balance, like Dr. Castle said earlier, you can't separate some of these issues. They're so intertwined and entangled, but then there's also a lot to be said about, I mean, we have to break it up into bite-sized pieces, so to speak. And I mean, we have to attack the issue somehow. We do have to have some kind of actionable steps. And how do we balance, you know, in facing the whole problem, not just a piece of it, but also being able to do something actionable. And I, like what you said, I personally really am interested in like local community leadership and seeing how that can have an impact on, especially at the like neighborhood and I don't know, parts of Louisville.
Can I jump in? I'm going to say something that may not make people happy, but we're talking, yes, change can be incremental, change can be individual, but we are public health practitioners, public health experts, public health researchers. So we're not so interested in the individual. We are interested in thousands and hundreds of thousands and millions of people at the time. So is there really room for incremental change, or do we just have to knock down the system?
Agreed. Because I absolutely 1,000% agree. Like, we think about it from a population, all of our work is from a population health standpoint, and going back to normal also equals going back to growing inequalities and gaps. So if we're sending people back into the same conditions, but just with mask on, we're just masking the issue. We're not addressing it. And so we really have to, like I said, be innovative, and we cannot continue to function under the same systems and policies and ways that we've always done things, because those ways we've always done things have brought us to
a really bad place.
Yeah, we keep coming back to this same place. And so really, what are we doing at those outer rings of the socio-ecological model to really impact population health should always be the core direction that we take in public health from that anti-racism perspective.
Thank you so much. I guess we're gonna do one like closing question for the three of you to give a little like quick response to. I mean, as quick as you can, and then we'll leave the rest of the time for the audience, virtual audience, to ask any questions if they'd like to do that. So for all of the panelists, I'll start with Dr. Wallis. In the context of this pandemic, what is at stake for health disparities looking forward? What current initiatives or policies at any level do we need to continue supporting, or what creative solutions are you hoping to see next?
So I think that this pandemic is literally a clarion cry for help. COVID-19 has magnified existing inequities, right? What we should be understanding is that there is a clear and present need for a true social network, safety net, and that we have to have universal access to healthcare that meets social justice standards. With universal access to healthcare, we start to be able to think about getting rid of some of those comorbidities because we've got preventive care, and that's big structural change. So as for creativity, I would really love to see our School of Public Health join with Simmons University to develop a 4+1 program, the same as that we have for our students here at the University of Louisville. And that program would create an academic and practical connection between Simmons and the School of Public Health that would result in more Black students and students of color achieving graduate degrees.
Thank you, that's excellent. Dr. Castle?
Well, I will echo you on that one. That's a great idea. And so, you know, adding on to that, for me, think it would probably happen at the federal level, but I know it could happen here at the local or state level, is thinking about addressing universal basic income so we can address poverty, and really change, you know, the lives and outcomes of people who live in neighborhoods. I bring it back to neighborhood because your zip code determines your life expectancy and all your health outcomes. So really in those neighborhoods that have been divested and really impacted by redlining, as an example, we really need to address universal basic income, and getting that access to, like Dr. Wallis was just saying, to universal health care. How do we do that and be innovative? And then the other innovative way is really dismantle all the systems that we currently have and build new equitable systems. We were just talking about education. Do we really have to go to school Monday through Friday from 8 to 3 or 8 to 5? Do we have to work a 40-hour work week? You know, yes, COVID-19 has definitely showed us highlighted all the inequities, but it's also showed us that we are spending more time on things we don't have to spend, or we need to be innovative in really how dismantle this social construct of how work and life and school should be. We know it can happen. Everybody adjusted and did online learning, but even further than online learning, education has seen gaps for a lot of kids. What are some more innovative ways that we can teach kids? Is it really sitting in a class from 8 to 3:30? Like, are we continue? Everybody says, like, I graduated in 2008 from high school, and everybody before me and even like now are like, oh, I didn't learn about life skills. You know, can this be the time where we really reimagine what school looks like and really incorporate learning life skills and, you know, anti-racism work starting early as elementary school, and really how we're teaching and what we're teaching and the foundation of that's just an education example. But how can we create new systems that are equitable and really address our lives in a different way is what I want to see at the local, state, and federal level. Here locally, like, can we work on making sure that we're raising the minimum wage? Can we think about increasing access to transportation? You know, what are those ways we can really change everyone's daily lives right now? And I think this is definitely the perfect time because we've learned and we've pivoted. But even with that, we have to address like the digital divide. How do we get people more access to the internet in a lot of these resources? Clearly it can happen, we see it, but how do we address it in equitable ways that are innovative? We really need to dismantle all the systems.
Thank you. That's a great answer. Dr. Carrico? Do you have an answer for the last question, or are you okay? I think you're still muted.
Sorry. You know, I don't know these answers. I really don't. I guess I live in somewhat of a concrete world that I want to say, if we're on a pathway, tell me what the pathway, let's decide on the pathway. I mean, as we are talking about the issues, we're talking, you know, very broad issues. And I think the broad conversation has to occur. But more importantly, I want to know what are incremental steps that we can take. Well, you know, we talk about, you know, changing the entire system. Well, conceptually, okay, but practically, is that going to be the answer that is most likely to be put in front of us? And even by saying that, then is that like a denial that the problem is of the magnitude that we all know it is? I think absolutely not. But I think that in order for change to occur, there has to be a pragmatic approach also to say, all right, what are the steps that we need to take? What is going to be our first step? How are we going to determine if the juice is worth the squeeze for this? And so I'm one that I'm like, I'm tired of talking about change I'm ready to implement change. But talking about it and not having a plan to implement, to me, it's a waste of energy, and it's a waste of human life. So, I'm ready to hear from you. What are first steps? What are next steps? And some may say, well, you can't decide a next step until you understand the scope of the problem. Well, then how are we going to understand the scope of the problem? What are the next steps to better understanding the scope? So until we get an agenda for change that is implementable, then I'm one of those walking around wringing my hands at the inability to bring any measurable help to the change that needs to occur. So that'll be a very broad answer, but it's really more of a challenge that, we have the youth of tomorrow, our future of tomorrow here at this time that is saying things have to change. Well, what? Let's tell us what, not in the, world hunger or world peace. It's what incremental steps do we need to take, tangible steps that we can get behind and we can invest in and we can make happen. Is this the way for change, or is there another way?
Thank you so much. Before we open it up to Q&A, I want to make sure that I get the chance to thank all of the speakers, Dr. Wallis and Dr. Carrico and Dr. Castle. I, at least myself, have learned a lot and benefited greatly from this, so thank you very much. And then I guess I'll let maybe Jason talk, and then we'll do Q&A.
Sure. Yeah. I really want to thank y'all again for joining this discussion, and it's been really insightful, and I really enjoyed you guys' responses. Just to add, because that wouldn't be Jason if I didn't add. So, I just feel like when we're talking about systems and destroying those and incremental steps, for me, incremental steps is what America has done. That's what America has done. It's not working. So my thing is, I don't want to say it like that, but it's really hard. It's not appropriate to ask the oppressed to inform the oppressor on of my oppression. I don't have to do that. You got Google, you got all this, research that, and then come back and then we can discuss. You also don't get to tell me what kind of steps I can take. That's also oppressive. Don't do that. Don't say, well, let's do this in stages. So when talking about what change is to occur, you need people at the table that look like me in power, so I can tell you. Because until then, you can't tell me that I'm not telling you, because I am. You're just not listening to me. And I'm not at the table to tell you that. So systemic oppression, guys. But yeah, so I just feel like, that's it. I really enjoyed, the perspectives, though. Seriously, it's awesome. It's amazing. I think we should open up for Q&A. If you guys want to put it in the chat, your question, or you can take yourself off and mute if you have a question for any of our panelists. Please ask a question.
So if no one's going to ask questions, I have a list of questions that viewers submitted before they entered the chat, and maybe I'll just randomly pick one or two, and you guys can decide how you guys want to answer. It's open to the floor. One of them is, how do you feel about Louisville's response to COVID-19?
Is it Louisville's response or Kentucky's response? Because they're intertwined.
It says Louisville, but you can go ahead and answer both if you want.
I think actually Kentucky, under our current governor, has done a really nice job. That's what I think. There's been a lot of points in time in this pandemic where, as epidemiologists and public health professionals, the best answer we've had is, I don't know. almost everything I said at the beginning was wrong. And that's been true for a lot of people. So I think that we're learning as we go along, and I think Kentucky's actually done a really decent job.
Agreed. I think so. I think Kentucky and Louisville did a great job. But I will throw in like capitalism started to impact everybody's decision, or probably was impactful, especially at like the federal level, for how we have pivoted through, I think, especially the summer. And now going in, like, especially going into the summer, as we think about like bigger holidays or like times people would congregate, the responses were great until this pressure and capitalism really impacted decisions that were made that have us where we are now. And then I would also say data collection, and not everybody really having a standard for how they're collecting and reporting data is also an issue. And honestly, I don't think we've seen the effects of, you know, the data we have, and how that's being used. We haven't really truly seen that impact, and we probably won't see it for a little while now, because of, I'm gonna liken it to capitalism for myself. I've thought about that because I'm just like, why are we in such a rush? Like, why do we have to, one, why we're in a rush to go back to quote unquote normal when normal hasn't really been good for a very large part of the population? And then two, it's still not, because it's not normal for everybody. For the people who are middle class and have access, or in jobs that afford them the opportunity to work from home or have the flexibility, then yes. But for people who are in a lot of service work, and service work like our, you know, corner stores, grocery stores, gas, like a lot of service workers, we truly do not know the impacts, because a lot of them have continued to work. Even think about postal workers, and like, I'm gonna call out, I know I'm one of the people who continue to buy things on Amazon, but thinking about, you know, Amazon Prime and people like that, and how we are trying to really get back to normal, or create a new normal. The decisions that are made are now really impacted by capitalism and not the best interest of the people. And so we really need decisions and decision makers who will make decisions for the best interest, equitable decisions for the best interest of the people.
Thank you. I think we will ask one last question, and this will probably be a conclusion to take home message.
Hey, Daniel.
Yes.
Hey, it's Felicia.
Hi.
I have a question for Dr. Castle and Dr. Wallis, if I can. Is that all right? You were both talking about data collection. So my question is about, how do we change the way data is collected? Are we talking about introducing new variables, or are we talking about redefining variables regarding race?
So I'm not talking about redefining anything. I'm talking about just doing it, because right now the CDC data set on COVID is missing variables. So we don't know enough about who has acquired, been hospitalized, or died from COVID. It's really spotty. So I'm not talking about changing anything. I'm just saying the CDC has to, well, the surveillance that's at the local level has to report correctly, as they should, back to the CDC. I get it that it's hard and it costs money, but if we're going to understand the overarching situation in the US, we just have to collect the data. And it's, if you go on the CDC website, it's super spotty.
And I will even argue, and I put a part of this in my dissertation, even a lot of variables that were collected prior to were not reliable. Because if you think about a lot of our federal, local, and state surveillance or like data, a lot of these data sets or variables vary based on the institution. So the way CDC collects race or different variables is very different from like the US labor statistics and all these institutions that we get data sets from. I would even argue that prior to COVID-19, the way data were collected by these institutions has not been, I wouldn't even want to say in a standard way, but they have not been consistent even prior to COVID-19, and going back to the resources at these different levels of how we are collecting them, it hasn't been there. So of course now it's still not there because this is something that hasn't been a priority.
Yep.
Thank you both.
Thank you, Felicia, for your question.
Thanks, Felicia. Okay, to conclude the talk up, we're gonna ask one last question, which is gonna serve as a take-home message. And this is more tailored towards students. How can we, as public health students, help with these issues in our community? What can students do to influence health equity in our city?
You're asking the students who are listening, right?
I'm asking the speakers. From your perspective, what can we do?
Oh, I'll tell you right now. One, okay, get out on the streets, yell and holler, do it peacefully, and the squeaky wheel gets the grease. We have to absolutely be heard. And I would challenge every single person, and I know a lot of you have done this, personally, because I've seen you there. We have to get out and yell and scream and vote.
You're on mute, Dr. Carrico.
If I can take another perspective, I would beg you not to go yell and scream. I want you to come and talk to me. I want to have conversation is meaningful. So I'm like, because I'm overwhelmed with the yelling and the screaming. And I think,
but if we don't yell and scream, nobody hears.
And sometimes, well,
both.
Some of us stop listening. And I think that not everyone is going to be able to become engaged in the conversation in the same way. And so I look forward to meaningful discussion where I can feel like we can come away with some ideas about what to do. I want to listen to perspectives, and I want to be able to counter that with thoughts that may or may not be congruent with the thoughts and the voice that I'm hearing. But that's, to me, that's meaningful dialogue. That's what I want. And some people may say, well, there's no place for meaningful dialogue. I would say that, with just like learning, not everybody learns the same way. Not everybody responds in the same way. And so if we want to get to the full population, we have to have ways to get to the full population. And so those of us that, that maybe don't respond in that way, it doesn't mean that we don't want to listen or are not interested. I just need to be able to hear and understand and feel like that I also can be heard. Because I think at the same time, in the last several years, we've had example after example where we continue to have large groups that are silent. It's not that they're not thinking and they don't have something to say. It's that they are not saying it. And it could be because they're angry or because they don't feel safe or whatever, so many reasons why dialogue doesn't happen. But I long for dialogue. So, and again, not everybody is going to approach it the same way, but I'm just asking for some of us that would love that.
So I think it's a couple of things students can do. So one, I will call on white students to really take time and engage in understanding and not asking our Black classmates or classmates of color to really explain stuff to you, but you taking your own time to really engage in understanding racism, race, structural racism, really how we got here, and doing some anti-racism work and understanding those frameworks, one, on your own. Because going back to a point Jason made earlier, it is not the responsibility of the oppressed to really continue to tell the oppressor what they should be doing. The oppressor has been oppressing for over 400 years, and some will argue probably even more than that. And so people have been yelling, screaming, talking silently. One person in a room who represents those groups sometimes, or if not, there are examples with a lot of those things. But not just at this point, but it's really gonna take a lot of people who have benefited from oppression to really challenge a lot of their counterparts who continue to be oppressive in the systems to change, because the conversations between the oppressor and the oppressed are not working. And even if you are yelling and screaming, and people's perceptions of protest or yelling or screaming, people are going to always have their own feelings. But at this point, it is really going to take a lot of people who have benefited for generations from oppression and systemic racism to do the work and really bring along their counterparts to bring about change. Because as much as we get more representation and people in the rooms and seats at the table are creating our own tables, the power that it really will go back to power, a lot of power that is rooted within our founding of this country, always are, as people talk about, we got to do this, or look at the systems, or think about the constitutional rights. Because if we really want to talk about constitutional rights, even to this day, the Constitution was created for old white men. And old white men, as Dr. Wallis pointed out, are still in those positions of power. So if we think about young white men who are benefiting, are mentees of a lot of these old white men, go in and talk to them and really bring them along in this work and do the work with them, then we can start seeing a lot of change, are really challenging them to dismantle the systems, and us really getting to a point of where we're redistributing power, or thinking about what power means and how it's exerted and talked about and utilized in a lot of places and contexts. So what I will say for students in particular, I'm going to talk to white students and students who benefit from oppression and systemic racism. You need to take the time to understand and do the work and speak up and speak out. It is going to take a lot of that work. So when you're going into the workplace and you're getting jobs easier than your Black classmates, and you are able to get into rooms that, even if I have my PhD and speak to and talk to people and my colleagues about things, they're not going to hear it the same from somebody who may not even have their PhD, but who looks like them, and they'll respect more. You need to really be doing the work right now as a student, so that when you go out into the field, you are able to also make that change and challenge your counterparts.
Woo! First of all, this makes me so happy, the discussion. And first of all, and second of all, I'm dramatic, so y'all just please forgive me. But thank y'all so much. I think, and just, we're gonna wrap it up, but just for me, as like SGA Council President, I just wanna say, for students who are on the call, like, challenge things that don't sound right to you in class. That's what you can do. If it doesn't sound right to you, it's okay to respectfully challenge your professor and say, I just don't, you got to explain that to me deeper. Like, you just have to explain why this is the way it is and why can't we change it? Because all the theories, all the stuff that we learn about, y'all, somebody created it. And it's not necessarily, it's not.
Guess who created it?
Right. And so it's like, it's not right. It's not correct. Like, it's not stamped that it's correct. Like that, because the theory doesn't say, okay, that's it. And so you can create your own, like, and even what Dr. Wallis says about like getting involved. And within any movement historically, if y'all look, there's so many different parts of a movement that you can be involved with. It doesn't have to be on the streets. You can be a contact for somebody, and just be, if I need somebody to come and scoop me from downtown, can you be that? Can you
post bail?
Or post anything. It could be anything. Provide
vote.
sandwiches.
Use your body.
Yeah, yeah, absolutely.
Use your body, right.
You know, it's so many things. And I think, like, you know, for when you look, just look at a recent, not a recent, but like if you look at the MLK versus Malcolm X thing, and it's only on my mind because I literally just like covered it. You know, Malcolm had a different perspective. MLK had a different perspective. And after reading his autobiography and his diary, MLK, it's like, MLK was also like, y'all not listening to me. You know, he had a thing where he said, you're not listening to me. And so Malcolm said, no, I'm gonna say it, and it's gonna be uncomfortable, and you're gonna be all right, and you're gonna have to be all right. And so there's no right way, and no one can tell you what a right way to protest is, no matter how uncomfortable it makes them. So with that being said, I just want to thank you guys, Dr. Castle, Dr. Wallis, Dr. Carrico. Y'all been awesome. I want to thank Daniel. Thank you, Tori. Y'all did an amazing job getting this together. I want to thank the rest of the SGA Council, Jules and Nana Amal and A. Ryan and Paige and Taylor. Thank y'all so much for your help. Thanks for all the faculty and staff that are on. Y'all are awesome too. But yeah, that's gonna end it, y'all. We're gonna send a follow-up email for like a survey. And so with that, y'all have a good night. Thank you so much.
Great job, everyone. Really
Thank
enjoy
you.
it.
Thank you, guys.
Thank you.
Thank you.